بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, I have the honor to be to introduce this lecture about the blunt chest trauma through the first radiology conference to be held in Yemen. And I hope for all the organizers, the chairman, and the audience, that they spend a fruitful time and a successful conference. You know that chest trauma is one of the most common injuries following the injuries to the head and the extremities. About 70% of victims with blunt trauma may suffer from the thoracic injury, and the thoracic injury accounts for about 25% of deaths due to trauma. Actually, most of the chest injuries are the sequelae of motor vehicle accidents, and we usually use the chest X-ray as an initial imaging modality for evaluation of possible injuries. Then CT is considered the most highly sensitive technique for accurate evaluation of the sequelae of trauma. Sometimes we need the help of the angiogram whenever there is a suspected injury of one of the major vessels like the aorta or the pulmonary artery. And ultrasound usually has a limited value in this domain, but it can help to detect the collection of blood in the pleural space and also the collection of blood in the pericardium. These are the possible sequelae of trauma to the chest, and we generally consider a post-traumatic lung opacity as a contusion and a post-traumatic pleural collection as a pneumothorax. Pulmonary contusion is considered the most common sequelae of blunt chest trauma, and it is seen in about 75% of the patients. And contusion is just a pulmonary opacity that can be delayed up to 6 hours after the onset of trauma. Then lung contusions differ from pneumonic consolidations in that they do not respect the fissures, and they are often located peripherally, and they also change rapidly compared to the pneumonic consolidation. Here is an example of pulmonary contusion. You got an opacity which actually simulate the pneumonia, but this opacity, whenever you have the history of a chest trauma, you should consider it as pulmonary contusion. And this chest X-ray was obtained a few hours later, showing some changes in the distribution of the opacity itself. And sometimes you may have the CT scan, and in this case, you see a clavicular fracture that is the sequelae of trauma, but there is no rib fractures, where in the left lung you can see extensive opacities representing massive pulmonary contusion. Pulmonary contusions start to resolve within 1 to 2 days, and the complete resolution within 3 to 10 days. And the focal opacity appearing 24 hours or more after injury is not a contusion, then you may consider the possibility of aspiration pneumonia or the possibility of fat embolism. Pulmonary laceration is also one of the sequelae of trauma, and this will result in a cavity in the lung, which may be surrounded by some sort of pulmonary contusion or opacification of the lung, or may not. And this cavity is due to the recoil elasticity of the lung, resulting in separation of the edges of the laceration, resulting in a cavity. And the complication of laceration include a superimposed infection, abscess formation, and bronchopleural fistula. This is an example of pulmonary contusion and opacity in the lung, and the pulmonary laceration where you can see a cavity with some air fluid level inside. And this is also a pulmonary laceration which is located in the right lung. After trauma, you get some cavities in the lung, and the diagnosis should be pulmonary laceration. And this is an example of the three sequelae of trauma: pneumothorax, pulmonary contusion, and pulmonary laceration. Cavity means laceration post-traumatic. Opacity means contusion post-traumatic. The third sequelae of trauma is lung herniation, and this is a rare consequence of trauma, but you may see sometimes through the rib fractures or defect in the chest wall, so part of the lung is herniating outside the thoracic cavity. And this is also an example of lung herniation in between the ribs, and you see part of the lung is located subcutaneously. Another example of post-traumatic lung herniation, and you can see some of the parenchyma underneath the pectoralis major muscle. Then the complications in the pleural space include the presence of pneumothorax, either regular pneumothorax or tension, the presence of hemothorax, either regular or tension hemothorax as well. And pneumothorax occurs in about 40% of patients receiving blunt chest trauma, and about 10 to 50% of pneumothorax thoraces are not seen in the supine chest radiograph. And this is important because if there is a pneumothorax, it should be diagnosed carefully either by plain X-ray or by CT in order to know that many of the patients with chest trauma may have mechanical ventilation, and this mechanical ventilation will lead to propagation or progression of the pneumothorax. Then there are some of the important signs in the chest radiograph to predict the presence of pneumothorax, and this is the most important sign, which is known as the deep sulcus sign. Whenever air is present in the pleural space in the supine film, it will collect in the costophrenic angle, and you can see that this costophrenic angle is very deep compared to the opposite one. And this, if the pneumothorax is present in the erect film, it will appear at the apex of the lung. In the supine film, it will accumulate near the costophrenic angle, resulting in the deep sulcus sign. And this is a good example of a pneumothorax with deep sulcus sign, and you see the draining chest tube. Actually, if the pneumothorax is rapidly accumulating, it will compress the mediastinum, resulting in contralateral shift, and also it will compress the diaphragm, resulting in significant depression of the diaphragm. Then at that time, you should consider this pneumothorax as tension, and here you can see a lot of air in the left pleural space surrounding a collapsed lung, and there is marked depression of the diaphragm and contralateral shift of the mediastinum. An accumulation of blood in the pleural space is known as hemothorax, and this hemothorax is massive when the blood exceeds 1 liter in volume. It may lead to shock and hypoperfusion. Then any fluid accumulating in the pleural cavity after trauma is considered as hemothorax, and you know that the blood has a high bar density compared to the fluid, And whenever you measure the attenuation value, you may be sure that this is blood, not fluid. And after some time, the blood will loses its density and it may simulate fluid, but it's important to know that accumulation of fluid in the pleural space after trauma should be considered as blood, not as fluid. And here is a post-traumatic CT scan of the chest. And you can see the presence of pneumothorax, the presence of pleural fluid, and you consider hemothorax, then this appearance is known as hemopneumothorax with some opacification of the lung indicative of pulmonary contusions. Also, you can see air in the subcutaneous tissues denoting subcutaneous emphysema. Also, air may leak into the mediastinum, and one of the best signs for diagnosis of pneumomediastinum is what is known as the continuous diaphragm sign. And if air collects in the mediastinum, you are able to delineate the whole course of the diaphragm because of the presence of air between the heart and the diaphragm. This is known as continuous diaphragm sign. And here you can see the diaphragm is clearly seen along its whole course, the continuous diaphragm sign. One of the most important signs also is to see air tracking into the root of the neck. This is one of the best signs to predict the presence of pneumomediastinum. Then mediastinal hematoma may result from injury to one of the mediastinal vessels, and hemorrhage is of course is more dense than the fluid, and you may be able to see the injured vessel as well. Aortic injury is a serious complication of trauma. It may lead to mediastinal hemorrhage and also may lead to hemothorax, which is usually located on the left side. The most injured the most commonly injured part of the aorta is the aortic isthmus, which is located between the subclavian artery and the ligamentum arteriosum. This is because of its high mobility. Then aortic injuries may result in intramural hematoma or dissection or the presence of pseudoaneurysm. These are the four grades of aortic injury. This is the most commonly injured part of the aorta. And we have grade 1 intimal tear or flap, grade 2 intramural hematoma, grade 3 the presence of pseudoaneurysm, and grade 4 you got rupture of the aorta. The plain film may be helpful to assess the aortic, to predict aortic injury, and there are some landmarks in the chest X-ray. They include number 1, widening of the mediastinum, number 2, blurring of the aortic knob. You can see the aortic knuckle, the presence of left apical pleural cap, and this is very important also, deviation of the trachea and the nasogastric tube to the opposite side, depression of the left main bronchus, and the presence of blood in the left pleural space. These are the helpful signs in the chest X-ray to predict the possibility of aortic injury, widening of the mediastinum, blurring of the aortic knob, pleural cap, depression of the left main bronchus, deviation of the trachea and the nasogastric tube, and the presence of some pleural collection. And here you can see the section in the aorta, and you see the intimal flap with leakage of blood in the mediastinum and also in the left pleural space. Then esophageal injuries are rare in chest trauma, but they carry a higher risk of morbidity and mortality. Then esophageal injury may result in pneumomediastinum, may lead to leakage of food or drugs into the mediastinum with consequence the development of mediastinitis or the development of hydropneumothorax. One of the best ways to diagnose esophageal perforation is to give the patient some of the oral contrast material, and then you can see that the contrast material is leaking into the mediastinum as well as in the pleural space. Finally, we came to the cardiac injuries, and the injuries of the heart may range from just the contusion to rupture of the heart. And many times you can see some blood accumulating in the pericardium, denoting hemopericardium, and you may also see pulmonary contusions and other types of post-traumatic injuries. The cardiac injuries are more prone to happen in age above 50, and if the trauma chest impact more than 50 miles per hour, and the past history of cardiac disease, sternal fracture, thoracic spine or rib fracture, hemodynamic instability, and marked precordial tenderness, ecchymosis, or contusion. Then you may got hemopericardium, pneumopericardium, or displacement of the heart outside the pericardium, what is known as cardiac herniation or luxation. Then, and this is what I mean by cardiac herniation or luxation after trauma. You can see the cardiac shadow, instead of being on the left side, it is now on the right side. This is a hemopericardium, blood in the pericardial space, and you can see the section of the aorta, hemomediastinum, and hemothorax as well. And diaphragmatic rupture is also one of the sequelae of trauma, and it is predominantly seen in young males, and this is the estimated incidence. And the left diaphragm is more vulnerable to trauma compared to the right side. There are some of the signs that can help you to diagnose diaphragmatic rupture. Number one is inability to trace the normal hemidiaphragm. As you can see here, this is the right diaphragm, and you cannot see the left one. You can see some of the abdominal organs inside the thorax, especially the stomach and the colon. And you can see the collar sign and also the dependent viscera sign. I will show these signs to you. The collar sign means constriction of the viscera at the site of the rupture. The dependent viscera sign means that the viscera became in contact with the spine because of the absence of the diaphragm. Then this is the dependent viscera sign. This is the stomach, and you can see it is intimately related to the spine because of the absence of the diaphragmatic copula. And this is the collar sign. Here, these arrow points to the defects in the diaphragm, and this is the constriction at the diaphragmatic defect. Finally, rib fractures may involve any of the ribs, and the upper three ribs are relatively more serious if they are fractured because of their intimate relation to the brachial plexus and the subclavian vessels. And rib fractures may result in hemothorax, pneumothorax, subcutaneous emphysema, and pulmonary contusions. Whenever you got three or more consecutive ribs that are fractured in at least two places, then you got what is known as the flail chest, which means that the affected side moves paradoxically compared to the rest of the chest. And this is very painful and hazardous also to the patient. One of the best ways to assess multiple rib fractures is to have the 3D reformatted images by CT. They can enable you to see multiple fractures, and it's easy to count the ribs in these beautiful images. And also, this is the way how to fix the rib fractures, especially if they are multiple. And this is also an example of the flail chest, where you can see multiple rib fractures and some pulmonary contusion. An external fracture is also one of the major sequelae of trauma because of its intimate relation to the ascending aorta and the heart. Then in this particular image, you can see the fracture of the upper edge of the sternum and the presence of anterior mediastinal hematoma. The best way to evaluate sternal fractures is to have this sagittal reformatted images to be able to see the sternal fractures, which are in many times are accompanied by fractures of the dorsal spine. Thank you very much.